So we talked about therapeutic diets, and I just want to make sure that you understand what the therapeutic diets are and what they mean. So NPO, it's a Latin word. It's a Latin phrase. But anyway, NPO means nothing by mouth. Okay, so if your patient has an NPO sign, nothing by mouth, not even water. If your patient has clear liquids, you need to understand that clear liquids is anything that you can pass a light through, and that is liquid at room temperature. So let's think about this. Cranberry juice, grape juice, black coffee, tea, broth, water, and popsicles. Okay, it's liquid at room temperature, and you can see through it. Full liquids, these are all clear liquids plus orange juice, milk, and ice cream. Okay, so it's all the clear liquids plus orange juice because the pulp is in there, milk, and ice cream. Soft diets, these are soft foods, usually low in fiber because they're easily digested. And patients with dysphagia will most likely have soft diets because it doesn't require too much chewing, because the chewing time could increase their risk for aspiration. And then we have the regular diets that you're probably used to. I mean, that's what you and I eat, regular diets, pretty much anything goes. Welcome to part 3 of Nurse Muse Fundamentals Master Student NCLEX Review. So we're going to start this presentation with prevention of foodborne illnesses. So we need to teach this to our patients, and we also need to remember this when working at home with our families and with our patients and in facilities. So we always need to have hand hygiene before preparing and eating meals. We always need to wash our hands in between touching any meat that is not cooked or any eggs that are not cooked. Always washing your hands while you're preparing food so you do not cross-contaminate. You need to teach the patients that they need to have 2 surfaces, one for rare foods and one for cooked foods. And then you also need to educate patients that they should use thermometers while cooking so that we can make sure that our food is not going to harm us in any way. So here on the left, there are some interesting facts over here on how many cases there were of associated foodborne illnesses in 2015. So that's a lot. We can prevent our patients from getting ill or even more ill by teaching them how to properly prepare food. Okay, so we're going to move on talking about capillary glucose. So you guys, I don't know if you've practiced this yet in the clinical or labs, but there are some concepts that you need to remember when checking a patient's glucose. So what we want to do is clean the skin with an alcohol swab, one of their fingers. So we clean with the alcohol swab, and then we let the alcohol dry completely on the patient's finger. We want to use the lancet on the lateral aspect of the finger and not on the finger pad. This is because the finger pad is very sensitive. You'll see with patients who have diabetes that their fingers are usually calloused, and it's more painful in the middle of the finger, so we do it kind of on the side of the fingertip. We want to lance it and then wipe away the first drop of blood that we see, and then use the second drop to actually get the reading. So this is important when teaching the patients how to take their own glucose, when they monitor their own glucose at home. And then these are steps that you should follow where you're monitoring glucose for patients in the hospital. All right, moving on to G tubes, NG tubes. So an NG tube, nasogastric tube, is a tube that goes through the nose into the stomach. So we use NG tubes for a couple of things. We can use them to decompress any fluid or gas from the stomach. And we can also use them for administering medications and feedings. So just be aware that there are 2 types of NG tubes. There's a double lumen and a small bore single lumen. So the double lumen, you probably heard of the Salem sump, 2SS, and this is used for decompression. It's a large bore tube, and it works as a sump where it filters air so the tube does not stick to the side of the stomach. So when you are using an NG tube for decompression, make sure that you use a double lumen Salem sump. These are ideal for suction. And then next we have the small bore single lumen. This might be referred to as a Dob Hob. It's smaller, it's skinnier, and these are best for medications and feeding. So just be aware that there are two types. The fatter one we're going to use for decompression, and the skinnier one we're going to use for medications and feedings. So how do you insert an NG tube? So we can use the NEX method, which is where we, here on the left side, you can see we measure from the nose to the earlobe, and from the earlobe to the xiphoid process. That's how far, it gives us a good estimate of how far we're going to put the tube down. So before we insert the tube, of course, we're going to lubricate the tip of the tube. This is not comfortable, and we want to make it as comfortable as possible. It would probably be worse if the tube was not lubricated. And while we are inserting the tube, we want to encourage the patients to swallow and sip water as we advance the tube. Okay? So this helps the tube go down when they swallow and sip water. We do not ever want to push the tube past resistance. And of course, after we push the tube in, we believe it's in the stomach, but we need to confirm this 100% using an X-ray. So after we put the NG tube in, then we call X-ray to get an X-ray of the stomach to make sure that the NG tube is in the stomach. You never want to use the NG tube until you have confirmed placement, because if you're not in the stomach, you can cause a lot of issues for your patient. So after you've confirmed placement and you're using your G tube to give medications or to give feedings, you can always check the gastric pH. So you don't want to x-ray your patient twice a day, every single day. So you can check the gastric pH of the stomach contents. If the tube is in the stomach, when you pull back on the syringe, you're going to pull back stomach acid. So we know that the pH, if the tube is in the stomach, should be less than 5.5. Okay, if you're not in the stomach, you're not going to get a pH less than 5.5. So remember that. Now our patient is done with the NG tube, so we need to remove the NG tube. So before we remove the NG tube, we're going to tell our patient what we're going to do and what to expect. We want to flush the tube beforehand. So look at your hospital's policies and procedures to see if you want to flush with air or flush with water. We just want to clear that tube out. And then what we're going to do is tell the patient to take a deep breath and hold it as we pull the NG tube out in one swoop. We don't want to prolong this for the patient. So he or she holds the breath and we pull one nice gentle swoop until the NG tube comes out. So let's talk about enteral and parenteral nutrition. So enteral nutrition, enteritis, we're talking about referring to the GI tract. So enteral nutrition is delivered straight to the GI tract. So for example, food that we put through an NG tube is an enteral feeding because it's going straight into the GI tract. Now this is preferable because if our patient can't eat by mouth, it keeps the stomach working. And as we just learned, we have the nasal gastric tube, the NG tube, and this is for short-term feedings. So we don't want to send someone home with a G tube. This is for short-term. If the patient needs feedings during the enteral route for a longer time, so let's say more than 4 weeks, we can put in a PEG tube. So the PEG tube is for longer periods of time. The NG tube is for just short periods of time. When we're feeding via an NG or a PEG tube, we always want to make sure the head of the bed is elevated 30 to 45 degrees because we don't want our patients to aspirate or choke. So we want to make sure that before we start a feeding, we always aspirate or pull back the gastric contents before we start another feed, because we want to see how much is left in the stomach. If it's larger than 500 cc's that come back when we aspirate, we do not return that to the stomach. But if there's like 30 or 40 cc's that come back when we pull on that syringe, then we can just put it back into the stomach. Of course, we want to flush our tubes with 30 cc's before and after every feeding or medication to keep that line clear, to keep the tube clear. And we want to change our tubing every 24 hours so that we don't place our patient at risk for infection. Now, Parenteral nutrition, para means around, so we're going to go around the G tract. So this is not into the G tract, this is around. So we're avoiding the GI tract. This type of feeding goes into the bloodstream directly. Now when we hang TPN, total parenteral nutrition, TPN, we use a central line, a PICC line or a central line to deliver the food via parenteral nutrition. When we do hang TPN, we need to discard the TPN after 24 hours because there's a ton of sugar in the TPN and we don't want more bacterial growth than that is already in there. So if we take down the TPN and the next bag is not available, it comes from the pharmacy, then we need to keep running dextrose to the patient because the TPN is full of glucose, okay? We can't just shut that off to the patient. So if the TPN is not, the new bag is not ready to hang, we need to keep administering 10 to 20% dextrose in water until the new bag is ready to hang, okay? So remember that. All right, so let's talk about urine characteristics. So we have expected urine characteristics, and of course, if any of our patients are excreting urine that does not meet these characteristics, we need to document and notify the provider. So we should know that urine output should be about 1,500 cc's per day. That's 1.5 liters a day. And our gold standard is 30 cc's an hour. So a patient should be voiding at least 30 cc's an hour. If it's less than that, we need to alert the provider because the kidneys are not functioning. When we talk about specific gravity, we need to talk about how concentrated the urine is. So with the normal limits, specific gravity of urine is 1.005 to 1.030. So if we have a low specific gravity, that means that our urine is very diluted. So lower than 1.005, the urine is diluted, and we all know that the urine should be clear but have a yellowish tint. So as a nurse, you're probably going to have to get some urine specimens, so we need to know how to get these specimens correctly. And over here on the left, I put a chart here so you can see the urine colors and what it's supposed to look like. So a clean catch urine, this is done while the patient is urinating. So if the patient has a penis and the penis is uncircumcised, we need to educate the patient to pull back the foreskin and clean around it before he starts urinating. If the patient is a female, we need to teach the female to separate her labia and clean away in between the labia any germs. So what we're going to tell the patient is to begin urinating into the toilet. We're going to stop midstream and then urinate into the collection cup and then stop urinating and then finish in the toilet. So we're going to get a midstream catch. Sometimes patients are sent home with a 24-hour urine collection, so we want to look at their urine over a 24-hour period. When we're educating our patients about how to do this, we usually start in the morning. So we're going to have the patient get up the next morning and discard the very first void of the day. So they don't need to collect the first urine. They need to collect the urine starting 24 hours after their first urine. And they need to keep this urine refrigerated until they bring it back to the doctor's office or facility for testing. You're going to hear a lot about urinary incontinence as a nurse. So there are different types of urinary incontinence. The first type I want to talk about is stress incontinence. So this is where urine leaks due to increased abdominal pressure. So if the patient says that he or she laughs or coughs or sneezes and urine comes out, this is stress incontinence. So people who are at risk for stress incontinence are people who have had multiple pregnancies or maybe multiple surgeries in the GU area. Then we have urge incontinence. So this means that the patient is out and about and all of a sudden a strong urge comes over the patient to go to the restroom, but the patient can't make it before it comes out. So how we help these people with urge incontinence is we teach them how to strengthen their pelvic floor by doing Kegel therapy or providing medications. Another common disease process you'll see as a nursing student is a urinary tract infection or a UTI. The most people at risk for UTIs are females because the urethra of a female is much shorter than the urethra of a male. So the signs and symptoms do depend on the patient. So a lot of patients, I'd say 95% of the time, will come to you and say, it hurts when I urinate. I feel like I have to urinate every 3 minutes. I feel like an urgency, but I can't, like maybe something that doesn't come out. I feel a burning when I urinate, or maybe the urine is malodorous. So the biggest sign of a UTI in the older population is confusion and abdominal pain. So many elderly patients, especially maybe in long-term care, if they're fine one day and the next they're confused, maybe with a fever, you should always go to UTI. Always think about checking for a UTI. When we're teaching patients how to decrease the risk of UTIs, we need to teach females to make sure they're wiping front to back. Patients should wear cotton underwear to keep moisture away from that area. Avoid bubble baths because these can increase the bacteria between the labia or on the penis, and they can be prone to a UTI. Teach the patients to empty their bladder regularly, to empty their bladder after intercourse, and of course to increase their fluid intake to keep washing out that system. So those are some teachings that you need to inform your patients of. So sometimes in the hospital, you might get an order to do a bladder scan. So why do we use them? A bladder scan uses an ultrasound to see how much urine is left in the bladder, and we use this to diagnose any urinary retention. So there are different bladder scans. You're going to see different types in different facilities, but usually you place the transducer above the pubic symphysis about 1 inch, and then you point it down towards the bladder. And then from there you can see what's going on in the bladder. You can get a reading. All right. There's actually a knob on the bladder scanners, and it says uterus or no uterus. So that's male and female. So sometimes it's easier if you just change it to no uterus, and then try looking at the bladder that way, especially if the patient has had a hysterectomy, or you can try and switch it back and forth and see which reading is the best, or how you can visualize it the best. So urinary catheters. Indwelling catheters, you've probably seen these. These are the catheter bags that are on the bed frame. So we call them Foley catheters. Foley is really a name of a company, but so a Foley catheter usually refers to an indwelling catheter. So an indwelling catheter, it stays in for a while. It's indwelling, it stays inside. We don't like to use indwelling catheters because they put the patient at huge risk for UTIs and other infections, but we have to use urinary catheters with certain patients. So if our patients are on strict INO, so we need to be monitoring their intake and output in a 24-hour period, or if our patient is comatose and unable to get up and use the bathroom, or unable to tell us when he needs to use the restroom. And then of course maybe a heart failure patient would be on strict INOs, and we need to see how much output that the patient has going on. So again, our biggest concern is called a CAUTI. It's a catheter associated urinary tract infection, but you'll hear the word CAUTI. So we try to get the indwelling catheters out as soon as possible. So as soon as your patient is ready for the catheter to be taken out, please make sure you contact the provider and get an order to do so. Then we have a straight catheter. So this goes straight in and straight out. So we use straight cath to get a sterile specimen, or if we use the bladder scanner and we see some urinary retention, we might get an order for a straight cath to see how much urine is actually still in the bladder when the patient is unable to void it out. Then we have suprapubic urinary catheters. So these are placed surgically through the skin, suprapubic, so it's above the pubic area. Then we have external catheters, such as a condom catheter for males. And then we have these wicking devices, and these are usually for women. And it's kind of like a suction device where you can put this suction device next to the perineal area, and it kind of suctions the urine out so that our patients aren't sitting in wetness. So of course we don't want our skin in moisture because that puts them at risk for a pressure injury. So just know that any care of an indwelling catheter is a sterile technique. Always use sterile technique when putting in catheters. The bag always must be below the bladder on the bed frame. We never put it on the bed rails because the rails go up and down and you can actually pull the catheter out inadvertently. So just put it on the bed frame. Every time we go in and check on our patient, we want to check for any kinks. Make sure that the tube is straight. We don't want any dependent loops. So sometimes there can be a loop in the catheter tube, and the urine can't get back into the bag because it's stuck in the loop at the bottom, like your loop is hanging down. So we need to make sure that there aren't any loops, there are no kinks, and that the bag is below the bladder. All right, now we're going to talk about constipation and diarrhea. So usually we say constipation is due to a poor diet, low in fiber. Emotional stress can actually cause constipation and or diarrhea, and other medical conditions. So when we talk about constipation, we're talking about decreased stool output and stool that is hard, lumpy, and painful. So we need to educate our patients on how to not become constipated. So we teach them to increase their fluids, make sure they have a high fiber diet, and of course increase their activity because we want to get that gut working when you're up walking around. On the opposite end, diarrhea, if we have diarrhea, we want to rest the bowel. So we don't want to eat anything spicy. Usually the brat diet is ordered. Of course, with our patients who are experiencing diarrhea, we need to watch their fluid volume because if they're having too much diarrhea, they're at risk for a deficit. So we want to increase their fluid intake and increase their fiber to bulk up that stool. Now again, we always want to make sure that the skin is intact with diarrhea patients because that excoriation can cause the skin to become impaired, and then we're looking at pressure injury. Ostomy. Okay, so the word ostomy means a surgically created opening. Okay, ostomy is a surgically created opening. And when we talk about a colostomy, we're talking about an opening to divert the bowel. So there are different places in the bowel that the surgeons can create an ostomy. Okay, so we can have an ileostomy where there's a small surgical opening created in the ileum of the small intestine. We can have a colostomy creating a small surgical opening in the ascending, transverse, or descending colon. Just remember that the closer we get to the rectum with our ostomy, the more formed the stool will be. Okay, so think about how the stool moves through the bowels. As it gets closer to come out of the rectum, it's more formed. So anything further away from the rectum, the stools should be expected to be more loose and runny. So you're going to be caring for ostomies as a nurse. So the patient will have an ostomy bag. So it's a bag that's attached by an apparatus to the ostomy. Our job is to educate the patient and also empty the bag when it is 1/3 full. And the appliance, I said that the bag is attached to the appliance. The appliance sits around the ostomy. So the appliance sticks to the skin, and then the bag sticks to the appliance. So if the appliance is leaking, we have to change the appliance as soon as possible. Remember, any wetness on the skin we don't like. It can cause skin breakdown. It's painful. We can get infections. So the stoma itself, that part that sticks out, should be red and pink and moist. This means that it has good blood supply. If it's pale or dusky or blue, we need to report this ASAP because that ostomy does not have good blood flow. We don't want that to die. So we should always be assessing the ostomy. Is it pink, moist, and looking like it has good blood supply? Now down here it says educate the patient how to cut the wafer. So again, the wafer is the ostomy, is the appliance. So they have to, the appliance of course has to be cut for each patient because not every ostomy is the same size. So you're just going to cut around the wafer to make sure that it sticks around the ostomy. We don't want it too big. We don't want it too small. If the wafer or appliance is too big, then that risks for drainage and fluid to come out. And if the ostomy appliance is too small, we can cut off the blood supply. So you'll learn in lab how to measure the ostomy and how to cut it so it fits nicely around the ostomy site without allowing drainage or without cutting off the supply. So laxatives. So if your patient has constipation, he might get an order for laxatives. So these are medications that promote the emptying of the colon. So these are usually pills. So, take a laxative pill, a PO, by mouth. We also have enemas, which are solutions that are instilled directly into the intestinal tract by the rectum. So those are solutions that you would put inside the patient's rectum. And then we have rectal suppositories. So these are little small suppositories that you do insert up the rectum. But just know that anytime you're going to give an enema or a rectal suppository, the patient needs to be in a certain position because it follows the GI tract position. So the patient will always be asked to be lying on the left Sims position with the right leg flexed over. Over here on the left, I have a diagram. You can see the left lying Sims position with the right leg over. And we're going to insert the enema 1 inch into the rectum. So we need to go past the sphincter and we want to push it along the wall of the colon, okay? About 1 inch inside the rectum. So best practices for enemas. We just remember the higher the bag, the faster the fluid will flow. So if you're giving an enema and you're holding it like 4 feet above the patient, it's going to run very fast. Okay, so we want to have the bag at least about 18 inches above the patient because the higher you go, the faster it flows. So if the patient starts to cramp or saying that their stomach is really not feeling that great, lower the bag. Lower the bag because you'll slow the flow. We want to educate our patients to try to resist the urge to go to the restroom for at least 10 minutes. So whatever we're putting in the bowel needs to work. So if we put the enema in and the patient goes to the bathroom within 30 seconds, then that medication or the fluid or whatever we're putting up there doesn't have a chance to work. So the longer it stays in, the better it will help. Sometimes you might be required to do a fecal occult testing, or this might be called a guaiac stool. Just know that this is just testing for blood in the stool. And we're not talking about bright red blood that you can see. We're talking about blood that maybe we cannot see with our eyes, okay? So this is for microscopic blood. So over here to the left is like a fecal occult testing kit that you'll probably see. There's an applicator here with the glove holding onto the applicator. We're going to get a stool sample. We're going to choose 2 samples from that stool, usually not close to each other. We want to get as much random sample as we can from the stool. We're going to put a sample of the stool on A and a sample of the stool on B using the applicator. And then we close this lid and then we flip it over and then we put the solution. Here's the solution on the left with the yellow cap on the specimen. And then if there is blood positive if there's in the stool, then the card will change a color. So usually the card will change to a blue, but it can also vary depending on the manufacturer. So make sure that you read the instructions, but basically just as long as you get 2 different stool samples and then you put the appropriate solution on, you can find out what to look for if there's blood in the stool. And then, of course, if we do see blood, we're going to document and contact the provider. Usually, the patient will be referred to a GI and most likely be referred to get a colon